Thank you very much for inviting me to give this talk today. Let's go on to the first slide. Next, okay. What we're proposing for the New Zealand STEMI pathway is not new, and in fact it's quite old. It's been around for some time, so it's always kind of surprising that sometimes it's difficult to get traction. This is the European Cardiac Society guidelines published in 2017, which basically underpins the New Zealand STEMI pathway, in that if you have early diagnosis of STEMI pre-hospital, you should be driven directly to a PCI-capable hospital, and if that cannot be done within 90 minutes, then you ought to see pre-hospital thrombolysis and be driven to a PCI-capable hospital. There is no role in STEMI care for transferring a patient to a non-PCI capable hospital. I work in, and this is sort of 1B, class 1 level evidence. My interest in STEMI as a non-invasive cardiologist started when I became a consultant 10 years ago, and that basically came around as I worked with some interventional cardiologists, and it was great when they were on call because we just took them straight to the lab and opened up that artery, and then when I was on call and I had some thrombolysis available to me, it all went to ratchet. So it really became upon me to try and sort this out. So the first thing I started to do was audit, and I looked at basically door-to-needle times. Because back in 2011, that's what we were all about, is actually just the treatment in hospital. And what was apparent was that if you came into hospital and presented directly, you got pretty prompt thrombolysis. But if you presented in pre-hospital services, you were kind of disadvantaged. So the first thing that we did was we looked at developing a streamlined pathway. And I spent 12 months of my life developing this lovely colour document that was really pretty. And we started to streamline the process for thrombolysis pre-hospital and in hospital. And that work shaved about 11 minutes off the door-to-needle time. 12 months, that was every month of the year shaved 1 minute off. And it was clear that there was a problem. And the problem was actually getting patients to hospital. So Nelson Marlborough, where I work, is a rural regional New Zealand. Although ambulances are arriving on the scene pretty promptly, it's about 15 minutes. It was taking them about 55 minutes to get to hospital because it's a lot of fields and a lot of sheep. Once they were getting into hospital, thanks to the pathway, they were getting thrombolysis pretty promptly. It's about 23 minutes. But then, because of the difficulties in accessing 24/7 angioplasty services that was kind of ad hoc and goodwill, they're actually getting rescue angioplasty services about 5 hours. So when I started to look at this data and we started to think about first medical contact to treatment times, which was a shift change for me, our first medical contact to needle times were over 80 minutes. And our first medical contact to rescue PCI times were over 5 hours. And if you look at the relationship between reperfusion and myocardial salvage, you see that it's time critical. And you've basically got 120 minutes to achieve reperfusion. So if you're plotting that out with what the system was like before the STEMI pathway, ambulance was arriving on scene here, we're arriving to hospital here, it was all good, but then they were getting TNK at a point where myocardial salvage was already down at 60%. And then the decision for PCI was being made 90 minutes later, and PCI was being delivered essentially beyond the period of benefit. So this isn't rocket science. What we needed to do was just move the thrombolysis pre-hospital, using that dead time of the transfer time to hospital, and then we need to, at the same time, make the decision about whether they're suitable for rescue angioplasty if they need it, and organising that at the time in order that you can deliver rescue PCI within the period of benefit. This is so obvious. And it's still not being done. And it's so simple. There is no new treatment here. There is no new drug, no new expense. This is just reconfiguration of what we're already doing and doing it differently. I've been talking about this for 5 years now. And this month I was part of cardiac network meetings, and these are the misgivings I've heard this year. This pathway is too expensive for New Zealand. We don't have the money. We are going to be flying old people around in helicopters, and what is the benefit of that to New Zealand? These chemicals are too dangerous to be in the hands of paramedics. And we're going to overrun our tertiary centres with STEMIs that they're not going to be able to cope. I'm kind of annoyed by this. So let me take you through it and rebut this. So when you guys are taking somebody to a hospital and you hear one of these misgivings to you, you can rebut it with some evidence. How old are STEMI patients in New Zealand in 2017? Punt, anyone? Average? 66. Median age, based in Auckland actually this data's from. This is not your 66-year-old patient, but how many 66-year-olds are in gainful employment in New Zealand? 40%. We're flying taxpayers around the country. Can we afford a STEMI pathway? So this is a group of sheep breeder farmers from the Czech Republic. And I don't know if you're aware, but the Czech Republic about 15 years ago backed a primary angioplasty service for the entire country. So these guys get access in regional Czech Republic to 24/7 primary angioplasty. These are farmers from the West Coast. They farm cows, not sheep. They're screwed. This is a great website, countryeconomy.com. You can go on and compare the GDP of any two economies all around the world. You look at the Czech Republic and New Zealand, our GDP is higher. Our national debt is lower. We can afford the New Zealand STEMI pathway. Can ambulance deliver fibrinolysis safely? $1,300 for a vial of tenecteplase with risks of intracranial hemorrhage. But looking at data from ANZAC's QI, which is our national cardiac registry for acute coronary syndrome, including ST elevation myocardial infarction, if you receive your fibrinolysis pre-hospital, you are more likely to receive it in the time frame of 30 to 60 minutes from first medical contact than if you receive it in hospital. And in fact, the median pre-hospital first medical contact to needle time is 42 minutes if you receive it pre-hospital and 65 minutes if you receive it in hospital. So you guys are better than us in district health boards in delivering this drug. Moreover though, this is data from the Northland STEMI project from Paul Davis. If you actually take clinicians, if you take doctors, cardiologists out of the equation, you guys can deliver this drug much safer by yourself than if you call me for advice. So prior to the implementation of pre-hospital, autonomous pre-hospital thrombolysis in Northland, 37 minutes, and the complexity there must be calling a cardiologist, getting them out of bed. And post-implementation, that was down at 20 minutes. With no differences in inappropriate rates of fibrinolysis. And your sensitivity and specificity for delivering the drug was exceptional. Surely, there are too many STEMI patients and they would overrun our tertiary centres. Well, let's be frank here. The mortality from ST elevation myocardial infarction is about 10%. And that is the same as the mortality from penetrating cardiac trauma. Who wants to leave this in Greymouth? Come on. Furthermore, we have emerging cardiac technologies coming online in New Zealand. The biggest one is something called transcutaneous aortic valve insertion. It's done in really old people, like 80. It's done because they're too ill for open heart surgery, so they're not great cannon fodder. The quality adjusted life years gained is less than for primary rescue angioplasty. The numbers for TAVI are about the same for rescue angioplasty. I said this to the Cardiac Society this year. We have to sort out core business in cardiology, and Rescue PCI for ST elevation myocardial infarction is core business. We ought to concentrate that before we develop strategies and pathways for these emerging technologies. That didn't get me many dinner invites. Undoubtedly, our poor access to rescue PCI services across New Zealand is a barrier. And if you look at currently what we deliver in Nelson Marlborough, we have a very streamlined access to rescue angioplasty, and we get about 43% of our patients who receive fibrinolysis have rescue angioplasty, and that's in keeping with data from the major cardiovascular trials. Overall in New Zealand, only 20% of patients who receive fibrinolysis receive rescue angioplasty. There is a massive weight of people out there who are not getting treatment that they require. And moreover, the ones that get it don't get it quick enough. And again, the median time for delivery of rescue PCI services in New Zealand is 4 hours. That is beyond the period of benefit. So we're spending a lot of time and money flying these patients around for no benefit. We need to sort our shit out. And in Nelson Marlborough, there has been a significant impact on delivering a STEMI pathway for particularly rescue angioplasty, rescue PCI services. So if you look at the sort of just our audited data, and you can see that there has been a significant reduction, particularly in the first medical contact to PCI centre times. So, in conclusion, there is really unnecessary inequity for access to regional revascularisation services in New Zealand. The STEMI pathway is cost effective, it offers no new treatment, and it is just a reconfiguration of existing services. And this can be safely effectively commenced pre-hospital, and fibrinolysis is better off in your hands quick than later in my hands delayed. So that's what I have to say on the matter. Oh yeah, this was it. This really did get me no dinner invites, with similar numbers to the New Zealand TAVI programme. Just a thought.
I'll just have to move the microphones up a bit. No offence, Tammy. Thanks very much, Tammy, and it's been great working with you to develop the New Zealand STEMI pathway. So we've heard about the data, we've heard about some audits, we've heard about the theoretical background about why we need a STEMI pathway in New Zealand and why it's absolutely necessary, and how we can do it for the same overall cost without anything new. So what actually is the New Zealand STEMI pathway? So this was finalised in 2016 by the National STEMI Pathway Working Group, delegated by the National Cardiac Network. The ambulance sector is a massive part of that. And since that pathway was developed, it's been further refined, and we're now in the stages of rolling out or implementing regional STEMI pathways. So recently, we got some very good news from the DHBs who have agreed to financially support the provision of pre-hospital fibrinolytic kits to every designated paramedic and intensive care paramedic, ambulance and helicopter in New Zealand. That's more than 90 minutes away from a PCI centre. So for us, that represents a substantial investment, and it's patients that are rural and are Māori that need this the most and have the most to benefit from pre-hospital fibrinolysis. And so we were really, really pleased to get that news, and what that has enabled us to do is crack on and start implementing regional STEMI pathways. So step one, identify STEMI, and the reason we have transmit ECG in brackets is because it's a nice to do but not necessarily a need to do. We've learned from our pilots that the more steps there are for the barn door cases, the more treatment is delayed, time critical treatment. Transmission of ECGs is a tool, it's not compulsory, it's useful if the diagnosis is unclear, but we shouldn't spend a lot of time trying to transmit ECGs if we're in a rural area, if there's equipment failure, if there's no cell phone reception. So it's something we should do, but we're not going to get hung up on it. The next step is to, as you do in hospital, to complete the fibrinolytic therapy / PCI checklist, and that's really to gauge the patient's risk of bleeding. We're going to empower our staff to administer fibrinolytic therapy if the diagnosis is clear. There are no contraindications or cautions to fibrinolytic therapy, and it is clear that the patient is more than 90 minutes from a PCI-capable hospital. I think Paul and the team in Northland have shown us that this is possible, and with good training and good oversight, it's absolutely doable. But the role of the STEMI coordinator and also the St John clinical desk with their on-call doctor is critical, because for the cases that do have contraindications or where the diagnosis isn't clear, that clinical safety net and that ability to seek advice is very, very important. So what are the pathways? As Tammy said, it's not rocket science. If we can get you to a cath lab quickly, we will, and by quickly we mean within 90 minutes of the diagnosis being made. And if we can't, we'll immediately administer fibrinolytic therapy on scene, irrespective of distance to hospital. So the interesting thing about distance to hospital, it's like, no, guys, it's okay. We're only 5 or 10 minutes from hospital. We'll just take them to for fibrinolysis. What we do know is if you're 5 minutes or 10 minutes from a hospital, you're about 40 minutes, maybe 45 minutes from fibrinolysis. Why is that? Because there's a door to needle time. There's reassessment. You've got to get another ECG. Someone runs in and tries to take blood. We've got the patient, we've got the drugs, we need to do it. The other thing as well is it's very, very difficult to get the person out of that hospital. So if they don't reperfuse, the oh shite, it hasn't worked moment at 60 minutes needs to be in a helicopter en route to a cath lab, not in an emergency department with no transfer arranged. After we administer fibrinolytic therapy, a really key thing will be transporting eligible patients direct from the scene to a PCI-capable hospital. We know that from Nelson audit data and from international studies that 30 to 40% of patients who receive fibrinolytic therapy do not reperfuse. We know that if patients have got good access to Rescue PCI, up to 43% of them get it. But at the moment, it's about 20%. That's not because all these patients reperfuse, it's because they do not have access. And as Tammy said, it occurs at 4 hours. Hospitals are designed to keep people in. There's a lot of pain associated with taking someone to the wrong hospital. If you do not reperfuse and you are in Greymouth, getting you out of that hospital is very, very difficult. It's an ICU transfer, even if it's an intensive care paramedic-led transfer, which we've proved both in Northland and Nelson Marlborough that pre-hospital staff, ambulance staff are absolutely capable of transferring someone who's had fibrinolytic therapy. Even using pre-hospital staff with all those time savings, it's still wasted time. So transporting eligible patients from the scene is very important. And in the clear-cut cases where a patient can get to a cath lab, getting the patient to that cath lab, telling the STEMI coordinator at the receiving hospital that we're coming is absolutely critical. And one of our challenges, or we like to use the term opportunity at the moment, is New Zealand's health sector boundaries, and part of forming regional STEMI pathways is getting patients to the right hospital from the scene the first time, irrespective of where they live. And that's really, really important. The funding must follow the patient. And there are patients out there that currently receive fibrinolytic therapy that are within 90 minutes of a cath lab. We talked about equity all through this conference. Lance O'Sullivan gave a great presentation about equity. You'll see there that where the light purple and dark purple there's a very, very low percentage of revascularisation from acute coronary syndrome and STEMI. Very low percentages of revascularisation. And funnily enough, those areas are the areas which do not have cath labs. So the heart attack centres or hospitals with cath labs. So the people that need revascularisation the most in the most deprived areas of New Zealand don't have prompt access to it because there are no PCI capable hospitals. So we'll never be able to make it equal. We can't move the location of Gisborne, but what we can do is treat the person in Gisborne with the same pathway so they have access to a cath lab when they need it. This is colonial New Zealand in 1843. As you can see, there's a lot of regions and a lot of boundaries. In New Zealand, we have 20 DHBs. And as I've said before, our challenge is getting someone who lives in a different DHB across a DHB line to the right hospital. And that is a massive opportunity for the sector and something we're working really hard to try and sort out. Collaboration and feedback is key. Now that we're in the process of rolling out the STEMI pathway, we have a New Zealand STEMI team Facebook group. The more of you that join, the more pressure is then put on Tony Smith to join Facebook. And we need our own clinical leader on there. So if you could help me out with that, that would be very, very good. If you join, you've just got to indicate what your involvement is in STEMI care and we'll approve your membership. The thing about STEMI and all clinical pathways is we need an open cockpit approach. If we get it wrong, it's okay. We need a forum for feedback, open discussion. And this is great because you've got the likes of Tammy, other cardiologists, emergency physicians in Auckland, St John territory managers, cath lab nurses, intensive care paramedics. Norma's on there. Norma commented on a case the other day. So the range of people on there is brilliant, and we post ECGs, anonymised case studies, so please join us on that page. This was someone that was flown from Blenheim to Nelson, bypassing Wairau Hospital, that arrived at Nelson Hospital in 80 minutes and got very timely primary PCI, whereas in the past they would have been fibrinolysed at Wairau Hospital and then been transferred out 60 to 90 minutes later using an ICU team and probably got our Rescue PCI or her Rescue PCI at 5.5 hours, which is consistent with what Tammy presented earlier. So just in summary, what we're trying to achieve, this is the current approach across New Zealand. We get on scene pretty quickly. We do a good job at getting to the patient. We get the patient to hospital fairly quickly, but still at about an hour. They get fibrinolysis about 23 minutes to 30 minutes later. Because they're in the wrong hospital and they don't reperfuse, a decision has to be made to transfer them to a PCI-capable hospital. They get their Rescue PCI at 5 hours. So what we're trying to do and what we will be doing with our regional pathways is rolling out pre-hospital fibrinolytic therapy to paramedics and intensive care paramedics. At the same time, we'll be making a decision in conjunction with a STEMI coordinator to transfer that will transport the patient from the scene to a PCI centre to enable the timely provision of PCI, but also the equitable provision. 20% is too low, not enough people have access to it, and for us that's a really important issue. Thanks very much.